Good morning, folks, and welcome to the 2022 version of our Future of Pediatrics CME program, celebrating over 23 years of shared learning. Not sure we foresaw quite this degree of success and longevity when we started this back at the turn of the century. That has a ring to it. But we're thrilled that we can begin to take a step or two back towards life the way we prefer it to be. Today's session is still going to be a hybrid session with folks both in person and a lot of attendees attending virtually, but bit by bit, we're going to get back to where we all want to be. And so I just want to remind folks that our future is bright. And we have the good fortune and blessing of providing care and nurturing the future and the next generation of children, of leaders, of pediatricians, and making a difference. It's not a better job in the world. So thanks for being here. We have CME learning objectives that are focused around really trying to do best practice in the primary care setting, understand how to identify concerns that may or may not need a specialty referral, and how to work best with our specialty partners in terms of what can be done and managed in the primary care setting and what our specialists do. We are accredited for CME credit. We'll put this up there a couple times so that folks understand that. This year, we're getting our CME credit through the Inova Health System. We will push this out a couple times, but you'll be able to get your CME credit. All of our presenters have completed conflict of interest statements. Some folks have funding from here or there, but no one has any commercial or industry support that is going to influence the presentations today. If you are having technical issues in this sort of hybrid setting, it's a little bit of a challenge, but if you're not able to get through, email us at phn@childrensnational.org. We're going to try to have someone monitoring and be able to help if folks are remote and having any challenges. We actually have a great agenda. We cannot, this year it seemed a little overly ambitious to try to do 2 full days and a whole evening reception and not even know if we should book a hotel. We're fortunate actually to have the auditorium here at Children's National's new Research and Innovation Campus. It's a safe space. We're going to be appropriately social distanced. We actually have a great full day session teed up. There will be breaks mid-morning, end of the morning, a little bit of a lunch break, another break or two in the afternoon so that folks will have time and opportunity to recharge and refresh as we work through the day. A lunchtime keynote and observation from our own Dr. Roberta DiBiase, just where we've been and where we're going with COVID and COVID-19. I keep hoping it's in our rearview mirror, but it keeps popping up ahead of us. So we will have some opportunity to get some perspective. And then a robust afternoon session, and we'll try to close before 5 so that those of you who have a bit of traveling can sort of get out there at a reasonable time. We're going to get started in right around 8:30, so we actually have a minute or two. I'm going to actually scroll back to the poll everywhere slide so that folks wouldn't have to spend extra time doing that. There we go. So if you haven't logged in, take out your cell phone. If you're working from your phone, you can just text PNetwork 550 to 22333, and that will sign you up. And then we'd like you to answer this question because we're just interested where folks are coming from. And we'll get started in about 4 minutes. Okay, we good? All right, hang in there for 1 second and we'll get started. So as we're seeing, we have a broad distribution of pediatricians from around the region. Thank you all for logging in and getting yourself ready for some audience response surveys for some of our upcoming presentations. We are going to try to start on time. We have close to 100 people who have logged in online and another 40 or 50 folks drifting in here. So we're kicking off with a great start. So thank you all for taking the time to partner with us, learn from each other, and continue to sort of build our pediatric community. So with that, we are going to move right into our morning session, and because we have a great team effort, we're going to really try to start on time. We have a team that includes Nancy Bauman, Maura Collins, Claire Lawlor, Sonia Sehgal, who are going to talk to us about multiple formula changes, and my infant patient still cannot eat. And those of us who've been in a practice setting know what we're talking about. So thanks so much. Nancy, you're on.
Thank you. Good morning, everyone. I'm Nancy Bauman, and it's a pleasure for us to be here today. It's harder to get an abstract accepted at this meeting than it is at any of our national meetings. So we're very honored to be here. Sadly, we have no disclosures. We present today on behalf of our entire aerodigestive team shown here at the bottom, and those of us on the left are presenting. Maura Collins is here in person, so one day we'll get her headshot, but we don't have it today, but she is here, so that is good. Our aerodigestive team evaluates patients with complicated aerodigestive problems, as you would expect, and many of those patients have chronic cough, recalcitrant asthma, or dysphagia, which is the term that encompasses all swallowing problems. And today we'll be focusing on a patient with dysphagia, an infant patient with dysphagia. Anna Wynn is our program coordinator. She is shown here, deservedly shoulders above the rest. She is the person who arranges all of our consults, and her email address is listed on this slide and is also available on our website if anyone would like to refer patients to our service. This is the typical patient that we would like to discuss today. A 3-month-old, full-term, otherwise completely healthy, neurologically normal infant who's breast and bottle fed. And when she feeds, she has irritability, back arching. Sometimes she coughs a little bit. Sometimes she spits up. And recently, she saw a lactation consultant, of course, who said, "Your baby has a tongue tie." What do we do with this baby? And this is what we'll be discussing. So I'd like to begin by discussing what a normal swallow entails. Maura Collins, our feeding expert, will then discuss how she evaluates patients, how you can evaluate patients, and simple strategies to help improve feeding in infants like this one. Dr. Sona Sehgal from GI will remind us that we should not first prescribe anti-reflux medications in this scenario. And Claire Lawlor, my partner, will discuss laryngeal anomalies that can sometimes cause dysphagia because swallowing and breathing are so linked in the infant age setting. Any baby with dysphagia who has stridor should certainly be evaluated for a possible laryngeal or anatomic anomaly, and she'll also discuss ankylosing in our 25-minute session. This is a very focused talk. We will just relay salient features that we think are most important to discuss. Dysphagia, again, is the broad term that encompasses any problem with swallowing. The etiology is massive. Aspiration refers to entry of food particles below the vocal folds into the trachea, and penetration is a near aspiration event where the food particles reach the larynx but don't go below. The larynx expels them. Dysphagia is common and affects actually 1% of all healthy, newborn, otherwise normal infants. And it should be considered, because many of these babies aspirate and it's silent, so it should be considered in any infant who has respiratory problems of unknown etiology. The newborn swallow is like a carefully choreographed ballet. It's a beautiful thing. And for us, as adults, the swallow is voluntary. We decide when we want to swallow. For newborns and young infants, it's an involuntary brainstem-mediated reflex activity. So I'd like to show the swallow here. This is a modified barium swallow. And a baby will suck 1 to up to 5 times before initiating a swallow. And during the suck, we see how the tongue elevates. I'll do that here so we can see on the Zoom screen too. The tongue elevates and pushes against the hard palate, and this expresses the milk. And the jaw elevates with the tongue, of course. As the jaw descends, as we'll see here, the milk is pulled back to the back of the tongue, and then a swallow occurs, and we'll see that here, and it moves the contents down into the esophagus. During that swallow, the constrictor muscles contract to move the milk down, and 3 important things must happen for the swallow to function well. The first is that the soft palate must elevate to close off the nasopharynx. The second is that the esophagus must open to allow the food to enter because the esophagus is tonically closed. And the third most important thing is the larynx that's bathed with this milk surrounding it at all sides must elevate up so it comes under the cover of protection of the epiglottis, and the milk goes on either side of it so the baby doesn't aspirate. And with that said, I will now turn the podium over to Maura Collins. Thank you.
Good morning. So there are multiple reasons that infants are referred for clinical swallow evaluations. Oftentimes in your clinic, you may encounter parents who come in with concerns for their infant's feeding. This chart here is an example of some important questions that can help to kind of guide the discussion about the infant's feeding difficulties. So some things we're thinking about first are, is the infant showing hunger cues? So we want the infant to be crying when they're ready to feed, or rooting or mouthing their hands to let parents know, I'm ready to eat. If this is something that they're not doing, that's a good reason to refer to a SLP or an occupational therapist for a feeding evaluation. Other questions that we ask are, is your child eating enough? So some parents will report, my child is only accepting an ounce of formula or breast milk, or maybe they only feed for a couple minutes and then they stop. If this is happening during feeds, again, they should be coming in for a clinical swallow evaluation. We also talk a lot about how long it's taking the infant to feed. So if they're feeding for over 30 minutes, there's a concern about their efficiency with sucking and swallowing. Also, if they're only feeding for a short period of time, why are they stopping feeding? That needs to be further evaluated. Other concerns that parents may have are if the infant is having coughing or choking while they're feeding, if all of a sudden they've started to just refuse the bottle or breast. And we see that a lot around the 2.5 to 4 month range when the infant suck becomes voluntary and is no longer reflexive. Also, if you're noticing that the patient is having a history of recurrent upper respiratory infections, we want to do further assessment. So during the clinical swallow evaluation, I first start off with doing a really thorough case history with the family, just learning more about how often the infant is feeding, how much they're taking, any signs of coughing or choking while feeding, and any behavioral cues. So is the baby turning their head and pulling away from the bottle or the breast? Are they starting to fall asleep, or can parents only feed the infant when they're sleeping? Then I go on to look at the infant's alertness. Are they calm and content? Are they starting to show us hunger cues that they're ready to eat and feed? I'll also take a look at their respiratory status. So we always know that it's most important that the infant is breathing comfortably before we try to introduce sucking and swallowing. Next, I take a look at the oral reflexes, and then I observe the infant feeding either via the bottle or breastfeeding. While the infant is feeding, things that I'm assessing are the coordination of the baby's suck, swallow, and breathe. I'm also looking for any sensory impairments. Are they having any gagging at the taste of the formula or breast milk? And then lastly, any stress cues that I'm noticing while they're feeding. And we're going to talk about those next. So infants can show a variety of stress cues when they're feeding. Some of these parents are not always as aware as feeding specialists are. So we try to do a lot of education about these during our initial evaluation and subsequent feeding therapy sessions. Some of the items listed at the top are things that are typically fairly easy for us to address because the infant is usually more interested in feeding, whereas the items on the second half of the list can be a little more challenging because oftentimes at this point the infant has started to refuse eating, and this can take a longer period of time to correct. So one of the first stress cues we may see is interior loss of formula, and that's on the top right-hand side of the picture. So that's when we're seeing the breast milk or formula drip out the side of the infant's mouth. This is oftentimes due to the fact that the flow rate is too fast, and we want to make sure to provide a break. Other things that we might notice is the infant starting to grimace, such as on that bottom right-hand side photo. And then some more of the more serious cues or if the infant is starting to splay their hands, that's telling us, hey, I'm getting really stressed out with feeding and I need a break. And if we don't recognize that pretty quickly, oftentimes what happens is the infant completely shuts down. You see them drop their hands to the side of their body and fall asleep. And at that time, feeding has really ceased. Fortunately, there are a number of different compensatory strategies that we can implement to help them feed safely. One of the first strategies we may look at is adjusting the flow rate. So the indication for adjusting the flow rate is if we're seeing things like the infant stopping their feed, they may be turning their head from the nipple or breast, or maybe they'll allow the bottle into their mouth but not latch to it to start to suck. That can be an indication that the flow rate is too fast. Other things we see, of course, is the milk spilling out of the infant's mouth or maybe pooling on the side of their cheek. We also may hear the infant kind of gulping, almost like you're chugging a drink. Or you'll hear a tongue clicking sound like this. That is an indication that the tongue is falling off the nipple, likely because they're having to break the latch because the flow rate is too fast. Fortunately, on the market, parents have access to a variety of commercial bottles. A study by Patos et al. Took a look at the different flow rates of the bottles. So oftentimes different brands, fortunately, have different bottle nipple flows, so it's helpful during the evaluation. If the current bottle nipple is too fast for the infant, that we have options of slower flowing nipples that the infant can use, but it's still kind of the same nipple shape, so that's easy for them to adjust. So here I've pictured some commonly used bottles. So first we have the Comatoma bottle, and we'll see that that one's more of a slow flow rate, whereas the Dr. Brown level 1 nipple has a medium flow rate, but fortunately, if we look further up in the chart, we see that there are other options of slower flowing nipples that we can try with the infant. Things like the MAM bottle is a medium flow rate, and then lastly, the Philips Avent nipple, which is a very common brand that parents use. This one happens to be a very fast flow rate, but if we look up on the chart, there are some other Philips varieties that have a slower flow rate. And oftentimes, unfortunately, parents aren't aware of what the flow rate is. They're just taking recommendations from family and friends about what has been helpful for their own infant. So this is an easy change that we can make. If the infant is exclusively breastfed, there's a couple strategies that we can do to help slow the flow rate of the breast milk. One of the first strategies I'll try to implement is having the mother recline back at about a 45-degree angle and then bringing the infant to the breast to feed. This position slows the flow rate out of the milk to make it easier for the infant. If that is still not working, the next strategy I like to trial is having the mother pump through her letdown and then bringing the infant to breast. The next compensatory strategies we're going to talk a bit about are positioning as well as pacing. So some indications for changing the position would be if we're noticing an infant who at rest is breathing very quickly. So sometimes this could be an infant with an unrepaired congenital heart defect, maybe some laryngomalacia. Also, if the infant is showing reflux. So this picture here is a position that's called the left sideline position. And this position has been shown to help infants feed more comfortably in terms of a comfortable breathing rate, and it also assists with gastric emptying to help prevent some reflux symptoms. The next strategy that we may try to implement is pacing. So we use this in infants. If you watch an infant and they're feeding and you're noticing that they're just continuously sucking and not stopping to take a breathing break. Oftentimes that's going to result in either them starting to cough or choke because they can't keep up with the flow rate, or they may just get tired and not be able to complete their full feed. So I'm going to demonstrate a little about what we do for pacing. So for pacing, what we're going to do is you would offer the bottle to the infant, allow the infant to suck about 5 times, and then tilt the nipple up in the patient's to the roof of their mouth to break the latch to force them to take a breathing break. We can also do a similar thing where either the bottle comes completely out of the mouth or tilting the bottle up to break the latch and just pulling to the corner of the lips. The last couple of compensatory strategies we'll talk about are parent and caregiver training, as well as thickening the formula or breast milk. There's some indications for caregiver training, of course, is if we're seeing parents or the infant demonstrating stress cues while they're feeding, that maybe the parent is not recognizing and continuing to feed the baby through. So some of these signs can be really subtle, but we want to make sure feeding, of course, is pleasurable for the infant. So we'll train the parents on identifying the specific stress cues that their child is showing and teaching them how to implement breaks or make modifications. Another discussion we often have with parents during the feeding evaluation is about issues with the infant only being able to be fed when they are sleeping or dream feeding. If a parent is reporting that their infant can really only feed when they are sleeping, that's a pretty big red flag that the infant is experiencing some discomfort during feeds. So we want to work with the parents on getting the baby to be alert when he or she is feeding, and also try to determine what is causing them to need to sleep during the feed. The last strategy that we'll implement is thickening the formula. From a swallowing perspective, my biggest indication for trialing thickening formula is, of course, only if I'm seeing aspiration of thin liquids on a modified barium swallow study or a flexible endoscopic evaluation of swallowing. And that is also if the strategies of like slowing the flow rate down or pacing or changing positions have not been effective. It can also be used, though, for treating infants with reflux. So there are two instrumental assessments of swallowing that we can use to further assess an infant's swallow function. What I would recommend, though, is if you have an infant in your clinic who is having feeding difficulties, I would recommend first having them seen for a clinical swallow evaluation and then allowing the SLP or OT working with them to determine the need for an instrumental assessment. Sometimes we can address the infant's feeding difficulties just within the clinic without needing to expose them to radiation for the modified barium swallow study, or maybe a little uncomfortable procedure for the flexible scope. So for the purpose of today's presentation, I'm not going to go into too much depth about the modified barium swallow study or the fees. I did put on your slides different advantages or limitations. Here I'm going to show a video of an infant who was having some coughing or choking with feed, so we determined the need to do a modified barium swallow study. Here we go. So what you'll see is the infant is starting to suck, as Dr. Bauman had talked about. And eventually what we're going to see is that the infant is going to have some aspiration where the thin liquid barium enters the trachea. The next type of swallow evaluation that we can do is called a fiber optic endoscopic evaluation of swallowing. One of the benefits of this, of course, is that it doesn't expose the infant to radiation, and it also lets you trial different positionings for feeding. So here is a video, and I'm just going to kind of point out anatomy first. So what we're looking at here, this is the base of the tongue. And this kind of white spot here, this will be the epiglottis that will invert over. And then as we forward the video, I'll show you the vocal cords. So each time we see the whiteout, that is actually the infant swallowing. They have a pretty timely swallow. Let me see if I can get, so here, we see the vocal cords and the top of the trachea, and this is a nasogastric tube going into the upper esophageal sphincter. So we oftentimes use the FEES study to be able to look at some of the structures as well, the benefits if we have concerns for issues with their breathing, if they're showing stridor, or a breathy vocal quality with a concern for vocal cord paresis. After the infant has been evaluated, we come up with a treatment plan. What we always want to make sure we're doing a treatment that is safe and also developmentally appropriate. So we put into consideration the things that we've seen during the parent interview, the clinical swallow evaluation, and any instrumental assessments. A big thing we want to kind of highlight is even if we're seeing an infant have aspiration during an MBS or a FEES, we're likely still going to have them do a small volume trial just so that they're able to maintain their oral skills for swallowing. We also consider things such as a need for referral to additional specialists or a need for feeding therapy.
Good morning. I'm the gastroenterologist in the aerodigestive team. And I really want to stress on the pediatricians how not to call everything reflux. And the gastroenterologists themselves have learned there are two big mimickers of reflux. So in a baby like this who's having feeding difficulties and respiratory problems, if you call this reflux, you will be misdiagnosing them. And this results in inappropriate medical treatment because you'll be prescribing unnecessary acid suppressants. The risk of unaddressed pulmonary damage will be ongoing from the aspiration. There can be poor growth and nutrition and development of oral aversion. So there has been a change, as I said, in the GI community as to what we call reflux. And our society has, in its latest recommendations on management of reflux, said that if you have a child who's presenting with the classical symptoms of reflux, irritability, vomiting, poor weight gain, choking, coughing, there actually are two main contenders for this diagnosis. And the first one is cow's milk protein allergy. So the recommendations are, if you see a child like this, do not start off with a PPI prescription, start off with changing their formula or having the mother eliminate cow's milk. The second big contender is oropharyngeal dysphagia. There are two questionnaires that can be used to assess reflux and dysphagia. I'm not going to go through each of these questions, but I would urge you to do that so that you're familiar with these questions. And what you'll see is there is a huge overlap between these questionnaires. A quick word about cow's milk protein allergy. All of us see us. The prevalence quoted here is 2 to 3%, which seems smaller than what we generally encounter. This is a non-IgE mediated allergy. So these are kids who are not going to present very sick with anaphylaxis. The presentation can be more upper GI, sometimes lower, or sometimes a combination of both. And for the purpose of the talk today, it's irritability, regurgitation, poor weight gain. Of course, diarrhea and rectal bleeding can also be the presenting symptoms. Majority of these babies will respond to the elimination of cow's milk from the diet. And the prognosis of this entity is good. Most kids will outgrow it by 1 to 2 years of age. Just a word about what are the different kinds of formulas that can be used if the baby is formula fed. It's the intact complex protein in a standard cow's milk-based formula that elicits an allergic reaction. As you break down this formula into peptides, the chance of an allergic reaction goes down. If you have a baby that you want to treat for an allergy, an extensively hydrolyzed formula or an amino acid-based formula is what you should choose from. A word about thickeners. As Maura just said, thickeners can be used for babies with oropharyngeal dysphagia and certainly in a baby who's regurgitating. They are of three main kinds. The oldest has been cereal-based formulas. Unfortunately, cereal-based formulas cannot be used with breast milk because the amylase in breast milk will break down the formula and you will not get the viscosity you're looking for. The second concern is arsenic. We know has contamination, rice has contamination with arsenic. But the good news is there are actually low arsenic rice cereals that are now available. The second big group of thickeners are commercial thickeners, which are based on gums or carbohydrates. Gel mix is the only commercial thickener that can be used in babies who are 42 weeks or more gestational age. The other commercial thickeners, unfortunately, should not be used in a child less than 12 months of age because they are associated with a greater risk of necrotizing enterocolitis. Lastly, puree foods can be used as thickeners, usually with a dietitian. So what would I do for this baby who's coming in with irritability, crying, back arching, intermittent coughing, and choking? I would not start off by prescribing an acid suppressant. I would consider an extensively hydrolyzed formula or ask the mother to eliminate cow's milk. I might thicken the milk if I'm concerned about, again, dysphagia, or this child is just spitting up a lot. Then going to a modified barium swallow if I don't have easy access to a speech language pathologist. However, if you're fortunate to have somebody like Maura, that is where I would start off.
Hi, I'm Claire Lawlor. I'm one of the pediatric otolaryngologists. My colleagues have done an excellent job laying out some of the functional and medical causes for dysphagia. Obviously, in infants, any anatomic abnormality from the nasal and oral cavity all the way down to the esophagus may contribute to dysphagia. We're happy to see your stridulous babies, your stertorous babies, your tachypnic babies. We're always happy to help you manage these patients. These are just a couple anatomic abnormalities at the level of the larynx. At the top left, oh, I have a pointer. I'm not going to use that. The top left is classically laryngomalacia, your squeaky baby, pre and post-operative, although most don't need surgery. On the bottom left, that is vocal fold immobility with an injection in the second photo, and that's to help the right cord that's mobile make up for the difference, the immobility in the left cord and close the larynx during swallow. On the right is a laryngeal cleft. It's pretty rare. So if we're talking about let's talk about a couple tongue tie babies. We can't talk about feeding issues in infants without talking about tongue tie. This is a mom who really wants to breastfeed, but she's having so much pain, and now she's stuck pumping. On your exam, the baby has this tight tie, and when you try to put your fingers in the baby's mouth, it's really difficult to elevate the tongue, approximate it with the palate. Baby struggles to project and move the tongue laterally. So tongue tie. Tongue tie is a bit of a fad diagnosis right now. A study has looked at the diagnosis and treatment of tongue tie, comparing the 1990s to the early 2010s, and the diagnosis and treatment has gone up over 830%. So that is not because there's something in the water now making babies have tongue ties. More women want to breastfeed. More people are trying to support breastfeeding mothers. There are more practitioners involved in the support of lactation consultants, OT, SLP, dentists, chiropractors. And people are realizing just how difficult breastfeeding is. When you look on the internet, cutting a tongue tie will be shown to improve all of your breastfeeding ailments, also your bowel movements, and make you more attractive. There is a huge financial incentive for many providers who are cutting tongue ties. I don't want to throw our dentist colleagues under the bus completely, but in the community, without insurance reimbursement, these ties can cost over $1,000 to cut. Everyone gives you anecdotal information about tongue tie. When you look for evidence-based medicine, there's a paucity of data and the quality of evidence is really poor. I would encourage you to look at the Academy of Breastfeeding Medicine protocol that came out in 2021 or the Academy of Otolaryngology consensus statement on ankylosing. I believe that was 2020. They're useful and they do an excellent literature search. So how do we support these dyads? Obviously, a lot of counseling, a lot of support. As we want to know who we can help. Evidence-based medicine with randomized controls trials and blinding has shown us that the only thing we can fix is nipple pain for moms. So that first case that we said, that might be a great candidate. We can't improve bottle feeding, introduction of solids, speech, no data for that. And then how do we go about diagnosing tongue tie? We shouldn't talk about anterior and posterior tongue tie and whether there's a band anymore. It's not an anatomic diagnosis, it's a functional diagnosis. Does the tongue move normally? Does it approximate the palate? Does it project? Much more important. How should we cut tongue ties? Laser seems really fancy. It's also super expensive. And the thermal damage may affect important structures in the mouth, such as the lingual arteries and nerves, the lingual veins, and the submandibular ducts. No anesthesia is necessary unless the child is much older. We don't use anything topical in the clinic. Finally, everyone loves to talk about exercises. There's no evidence that they prevent retethering, and they may cause oral aversion by traumatizing the surgical site and introduce infection. There is so much more than just a tongue tie that can affect breastfeeding. This slide you can look at yourselves at home, but it's just to highlight we can't fix gassiness. Torticollis, micrognathia on the baby's anatomy, mom's anatomy may include flat nipples or severe engorgement, insufficient glandular tissues. There's not enough milk in the breast, so the baby's not interested in the breast. Mom is giving a lot of formula, so the supply is low and the baby gets unsatisfied at the breast. I actually spend more time with the families that don't have tongue tie, just helping support them, than I do with the ones that really easily need a clip. Just very briefly, lip and buccal ties are anatomically normal structures. There's no evidence to support cutting these for any reason. They're frequently cut in the community, again, for lots of money. Especially buccal ties, be very cautious. They may weaken the support of the buccal fat pad and impair a baby's swallow. These are a buccal tie. Lip dye. Thank you so much. Any questions?
Thank you very much. There is one question on the Zoom Q&A. Question is, can you assess most babies clinically to avoid swallowing studies?
I would say that yes, most of the swallowing issues can be addressed with a clinical swallow evaluation. However, if the infant is having a lot of coughing or choking, or they're having frequent upper respiratory infections, we've tried to implement strategies with the pacing or adjusting the flow rate, then we do need to proceed to an instrumental assessment to further look at their swallow. With your infants with history of recurrent upper respiratory infections, we do know if they're under the age of 2, there's a higher incidence of silent aspiration. So in those cases, it can be more worthwhile to do the instrumental.
Thank you.
We do want to stay close to our.
Yeah, I think we could probably take one question in the audience. Maybe we have one here.
Hi, thanks for a very nice presentation. I just have one quick question about the slide that you showed about the flow rates, slow to large flow rate, which ranged from almost 5 ml to 30 ml. Is it like per swallow, per minute, per what?
So it's per suck, how much they're
Per suck.
expressing.
And then what do you recommend for a normal full-term baby with everything normal, like now that we know so many flow rates exist? Which one should we choose to start with, like medium or the?
Yeah, typically starting with medium, and then
Medium,
you have
okay.
the availability to go slower if needed.
Okay, thanks.
I want to thank this team. What a power quartet to be able to pack so much information actually into, a half-hour presentation. For folks who are here or folks who are doing evaluations online, if there's additional information, if some of these sessions really resonate and you want more, we have the ability to do additional grand rounds and other sorts of sessions to sort of provide learning and support for our practices and our practitioners. We know busy pediatricians in a busy day see a lot of new babies and new moms and families who are struggling with feeding issues. And what doesn't necessarily come across in the session is how stressful this is for the new families. And so we really appreciate the team approach and perspective, and feel free to sort of reach out for additional information.